Wonderful. Well, despite the conversation we had last time, Dr. Lisa Fitzpatrick has kindly agreed to come back on the channel. Lisa, welcome back. Great to see you again.
Hi, Dr. John. So great to be here. Thanks for having me.
I think it was about last summer 21 we spoke. So
yeah,
we got a lot of positive feedback from that.
Wow, yeah.
Yeah. So Dr. Lisa Fitzpatrick is an infectious diseases physician. I believe you worked with CDC for about 10 years, Lisa, as an epidemiologist.
Yeah.
Is that good? Yeah. You're now a clinical professor with George Washington School of Medicine as well, so you're still doing that?
And the School of Public Health, adjunct professor, yeah.
Yeah, wow, yeah. But the main thing is you're now focusing really on preventative health strategies. So my kind of impression is that you were dissatisfied with the existing structure. So you founded Grapevine Health. Is that basically what happened?
Yeah, well, I've been thinking about something like Grapevine Health for a while because in the United States, we focus a lot on treatment, medications, seeing people in the clinics when they're sick. And I think we need to put more emphasis on keeping people healthy out of the hospital. And even in my own case, I mean, it can be very difficult, but if you don't have the support systems and the natural resources available to you, it's really hard to do. And so I started Grapevine Health because I think the root of a lot of health and avoidable disease is not understanding. So low health literacy or not really understanding health information, how to use it to keep yourself healthy, not understanding what doctors are saying when you're in the office or in the hospital. And so we wanted to find a way to provide relatable, trustworthy health information from trusted messengers. So most of our work is in Black and Brown communities here in the U.S.
And you're actually in DC, aren't you, at the moment? In Washington?
I am in DC, but throughout the pandemic, we've been to quite a few different cities and states. We've been to Alabama, Louisiana, we've been to Michigan, Georgia, let's see, where else? Pennsylvania, New York, New Jersey. So these issues we're trying to address related to trusted health information, it's a universal problem. So it's not just in DC. So we don't want people to think they can't reach us because we're based in DC.
So there's communities with particular problems with health literacy in various parts of the state. So are these communities where there's particular problems with health literacy sort of localized in particular areas typically, or are they diffused over an entire city?
Well, first I'll just say, there are data and studies to show that health literacy is a problem writ large, so not just for certain populations. And it depends on how you think about health literacy or understanding health information. So if you ask someone to explain how the health insurance works in the United States, how their health insurance works, most people won't be able to tell you. So that is a form of health literacy or understanding the resources available to you. But we specifically work in underserved communities that may have low background literacy. And if you have low background literacy, there is a mountain of data that show that you may have worse health outcomes or may use the health system in more costly ways, such as going to the emergency room, or I guess there you call it casualty, or being hospitalized for avoidable reasons. And so there are a lot of reasons for that, not just low health literacy, but we focus specifically on populations that suffer from health disparities or lack of access to convenient healthcare.
Now, I want to talk about the pandemic in a minute, Lisa, obviously, and how things are going there. But what kind of background health problems are we talking about? What information do you need to give to address what forms of health problems or pathologies?
It's mostly chronic health conditions. We see people with avoidable and preventable health conditions like heart disease, diabetes, overweight and obesity, high blood pressure, cancer. And so in a lot of the communities we work in, people have the highest rates. So these are mostly some of our Black communities. We have the highest rates of these chronic conditions for a variety of reasons. We live in communities that don't have ready access to subspecialty care, or we may not have grocery stores that are readily available. I lived in a neighborhood that had one grocery store for 70,000 people. And some people would take 2 buses just to get to the grocery store. So
Wow.
if we're telling people they have to eat fruits and vegetables instead of fast food, but then they don't have ready access to fruits and vegetables or can't afford them consistently, that's a problem. So it's not surprising that some of our underserved communities are struggling with their health.
So your objective would be to give sort of nutritional advice on what constitutes a good diet, but then sort of practical advice on how you actually fulfill that in a contextualized situation like you were in.
Yeah, but before the pandemic, we wanted to provide access to relatable health information about a wealth of things.
Yeah.
You know, heart disease. How do you prevent heart disease? What is diabetes? How do you avoid having your kidneys shut down? You know, a lot of people we encountered didn't understand the relationship between high blood pressure and kidney disease. I think a lot of people don't understand that. But I think you have to understand this before you can actually take an action. So that's really where we want to focus to begin, because when you help people understand, we've learned that it builds trust. And then they'll listen to you, and they may take your suggestions about why they should have a regular primary care provider or get a physical exam, just to be most simplistic about it.
So practically, how do you get this information from you through to the people that want to that will benefit from this? I did like the expression proximal help. You know, you're kind of close to the individuals, aren't you? But how do you do that? Is it walking around the community? Is it talking in community centers and churches? How do you do this practically?
Yeah, it's both. But the way I have realized we need to scale what we do is through technology. So yes, it's walking around, doctors like me being in the community, on the ground, answering people's questions, or just listening or having conversations with people to understand what they're confused about. So for example, one day I was out and a woman asked me, how can you survive a heart attack? And I said, well, what do you mean? She says, well, I thought if you have a heart attack, your heart explodes. And so we hear things like that all the time. So being available to people to help demystify this health information is really important. But if you can capture it on video and then put it on something like YouTube or on social media so people can consume it on their phones, that builds the brand for us because they know they can come to us if they have those questions. But it also provides a resource for them, because some people are bashful about asking a question they think they should know the answer to. So the way we get to people is being on the ground in the communities where they are. We also partner with organizations who already have built trust, and then we work through them and with them to connect with folks.
So you're kind of walking down the street, and obviously you're quite well known now in this. You're in your neighborhood and other neighborhoods. Do people say, "Oh, Dr. Lisa, can you?"
Yeah.
Does that happen?
It does. It happens a lot. I was walking with a friend the other day, and I saw someone I knew, and she says, "Does everybody know you?" No, everyone doesn't know me. Plus, I'm not on TV. I actually have not been very aggressive about being on television because I've also learned throughout the pandemic that people are becoming very distrustful of TV doctors. And so to me, it's important to really keep up the personal connection. I'm not on the ground every day. I mean, there are things to do administratively and operationally with, running Grapevine Health. But when I get out in the community, I hear a lot of things you wouldn't normally hear. Even if I were seeing a patient in my office, I might hear something completely different. So I also have a story for you about, and I may have told you this last time. I don't remember if it happened then.
Go for it.
But I was walking down the street looking for someone who had returned my purse. And I was so grateful. So I was looking for this gentleman. And I stumbled upon 6 or 7 men sitting in an alley. They were hanging out. And I stopped to talk to them. And they didn't believe I was a doctor. And I said, why don't you believe I'm a doctor? And they said, because doctors don't walk around in the alley. And I said, well, this doctor does. So I had to go home and get my white coat and my badge to show them I'm a doctor. And someone even looked me up on LinkedIn. So it means that we need to be more visible in the community.
I guess that's a good example of stereotyping, isn't it?
Absolutely. I've even had someone refuse entry to me because he didn't believe I was a doctor. He'd never seen a Black doctor, which is amazing to me. In the place I live, there are a lot of Black doctors, but
sure, I
didn't look the part. I didn't have on a white coat and a suit.
Yeah. I have credibility problems as well. I won't worry about that. So, now one of the words you use is demystifying on your literature, Lisa. Tell me what you mean by demystifying.
It means helping people understand something that's complicated to them, and breaking it down that it's very simple to understand. And an example of this is when we talk about vaccines throughout the pandemic, lots of questions about how vaccines work. Particularly with this messenger RNA. I mean, it's new to people. It's just getting on the radar, even though it's not new. They've been testing it in humans for decades, but people don't really understand that. And so in trying to explain to people what vaccines do, I use a lot of metaphors and analogies. So I say a vaccine's like a dress rehearsal. It's getting you ready for the big show. It's like practice. Or I might say vaccines like a bouncer at the club. If you show the bouncer a picture of the person who shouldn't come in, when the bouncer sees that person, then they can keep them out. Or there are so many different metaphors you can use. And that's what I mean by demystify. So put it in a language that's accessible instead of using big words and complicated scenarios and information.
So you really are starting at a really basic level with people who have almost zero health literacy. Really, it's really is a grassroots level. That is, I mean, if you take my channel for example, I kind of aim it, I suppose, at the average interested, literate, intelligent lay viewer.
The people who already do a lot of reading and research on their own, who already have some level of understanding, and then they take it to the next level.
Yeah.
Because I've had people say that I'm talking down to people. Well, that's not my audience. If you think I'm talking down to you, you're probably not the primary person I'm trying to reach, because the only reason I'm doing this is because my experience, my patients, even people in my family, people we've talked to thousands of people throughout the pandemic who don't understand these concepts. And so it's complicated. I mean, there are even things we don't understand, and we're, highly educated in the sciences. So I think what happens is, especially TV doctors and a lot of people who are very visible, they take for granted what people know. And they talk at this level because we believe people are following along. So an example of this is a woman who asked me why she should get vaccinated because her COVID-19 test was negative. So just think about that for a minute. So if the person's coming on just saying, well, the vaccine efficacy is this, and, we are seeing reductions in hospitalizations, and the hazard ratio is this and that, and the person is still thinking, but my test was negative, I don't need to listen to that.
Yeah.
There's a need for this kind of communication. And it's not just the people you think. I think there are college-educated people who have called me and said, this is too hard for me to understand. Like, can you help me, break it down? And so there are more people out there than you would think, because I think the people feel embarrassed that they don't know things, but that's why we're here. No judgment, no shame.
No, I agree completely with that. But why is it that there is such ignorance about such relatively basic concepts? Is it that it's not taught in schools? Is it that people have missed out on educational opportunities?
Yeah, well, I tend not to use words like ignorance, but yes, I think we especially in the United States, we need to do a better job explaining and integrating this basic concepts about the body, science in our schools. And I see this all the time, even with, again, college educated people, when I take my organ model out. And I should show you my organ model. I'm sorry I don't have it here.
Yeah, it's like a mannequin. I've taken a few bits of videos myself. Yeah.
And so when I take that on the street, even college educated people can't name most of the organs. So it's not that, folks are ignorant. It's just that we need to do our part to make sure they're prepared to understand these things. And so imagine if we have that level of understanding at baseline, and then something complicated like this pandemic happens upon us, and then we're developing a vaccine so quickly, and the science, we're trying to communicate the science on top of the low level of understanding at baseline. And then there are mixed messages. I mean, this is a perfect storm for distrust, confusion, and just sort of intellectual chaos, I think, because people don't know who to believe, or this document is conflicting that document. And on top of it, we started releasing data before they were even peer reviewed. So I think it's completely understandable to me that people have trouble.
So generally, is there a problem with trust in medicine, or is it in individual doctors? I mean, I think you've clearly described a lack of trust. Who is the lack of trust in? Is it lack of trust in governments? Who is it not? Who is not trusted?
Well, I think there's enough just distrust to go around. Definitely in government, John. But this is historical, especially for Black people in the United States. I mean, your viewers probably have heard about Tuskegee by now. It's an experiment that happened upon Black men for almost 40 years. They were diagnosed with syphilis, but the treatment was withheld from them so that the physicians and researchers could study the natural history of syphilis. And that's how we know so much about what happens if you don't treat syphilis. And so even though people haven't had experiences like a Tuskegee right now, that information is passed down from generation to generation. And even though people may not have the vocabulary to talk about exactly what happened, it's the notion that one group of human beings could impose such horrific treatment on another group of human beings. And then it's reinforced when people actually go to the hospital, even now, because people feel disrespected often. A lot of the Black patients I've seen, people in the community, feel that they're very disrespected and unheard in the healthcare system. And so we're talking a lot about health equity now, but we're not having enough conversation, I think, about where this distrust came from and what we're going to do about it. How do we hold people accountable? So I think the distrust is well warranted. There was an article published in the New England Journal about how the health system needs to be trustworthy. So we talk a lot about building trust and getting people to trust us, but are we trustworthy as health systems and as providers? So, I think there's a lot of work to be done at the systems level in the C-suite, owning why people see us as untrustworthy, and then figuring out what we can do about that. We all have bias. It's innate in a lot of us because of the way, whether we're raised or the images we see, we're bombarded with, feed our biases. But we have to own that and work on it, each individual.
I mean, I get the impression the pandemic hasn't done too many favors in terms of trust, because there's been so many people that are supposedly big leading experts who've made very fundamental mistakes. And my trust in official organizations is certainly much less now than it was at the start of this pandemic. So I can kind of relate to that, and I do think we need reform in the way that healthcare is delivered in these national organisations, in these international organisations. And I agree that I think part of the main antidote to that is the individual trust between the clinician and the individual patient. If you can trust the person that's treating you or trust the person that's giving you the advice, then in a sense, the international and the national organisation don't really matter. It becomes an interpersonal exchange.
Yeah, I did a little work on this, and I would ask people, how do you determine whether or not you trust your doctor? And the number one thing I heard was that the doctor listens to me. And I said, well, what does that mean? And so the nuances of body language, they tried to describe, well, I can tell, if they don't look at me, or when they stop looking at me, or they put their hand on the door, and then I just feel like they're too busy for me.
Time is it now? Oh, yeah. Sorry, go on, Lisa. Yeah. No, I agree completely.
Yeah, exactly. And I think someone even said, the doctor looked at their watch, and I felt like, okay, well, I'm intruding. And that's horrific, because the patients are here. We're here for them.
They're our raison d'etre, aren't they?
Absolutely. And so I think, we forget that in the rush. I gave a talk to a group of physicians last year, and one of the questions was, we're so busy. The administrative burden associated with practicing medicine now is just so high, and we're pressed for time. The visits are truncated. How do you take the time to listen and communicate plainly? And there are no easy answers, but I think you have to make it a priority and figure out how to do that. So the other thing I would just say about trust, John, though, is that this pandemic was so politicized from the beginning. And I think we're still reeling from that, and we will be probably for many years to come. And when you have something so complicated about, having to do with a pandemic and a new vaccine, particularly a new vaccine that was produced in record time, you should not have politicians communicating science or communicating about this process. That's a problem. And I think because of that, we've irreparably harmed some of the relationship with the community, because some people will never, ever trust us or believe us again. And also because we've never really taken the time here in the U.S., I think, to bring people along and help them understand, well, how do you conduct a research study? And what is the process like? And how do you determine if a drug is good enough to go to market? And when does a drug go to market? People didn't really understand the nuances of that. And all of a sudden, we bombarded them with all of that information. And the information was conflicting. And now they don't believe a lot of the things we say. So that's the problem we're going to be wrestling with for a long time now. So
what do we do about that, Lisa? I mean, that's a pretty fundamental issue, isn't it?
It is. But that's why we have organizations like Grapevine Health. Because I think the messenger matters. So I think the reason we have been successful in reaching some of the folks in the Black community who haven't wanted the vaccine is because we sent a Black doctor who maybe grew up in a community like that, who is seen as a more trusted messenger for this information. And I had a gentleman tell me that when I said, well, why don't you want to get vaccinated? He said, well, I need to see if other Black people are associated with it. So I was able to tell him, well, I was in the research trial. Like, what questions do you have? And I could have a conversation with him about Tuskegee in the context of wanting him to think about a vaccine right now to protect his, himself and his family, because he had multiple chronic conditions. So that the messengers matter, whether we want to accept that or not. Because you can deliver a message to people in the UK and it will be heard in a very different way than if I deliver the same message. And it's no different for Black people or Hispanic people here in the United States. It's important for us to recognize this and value it.
Yeah, we're two countries divided by a common language, that's for sure. But it's even worse than that. You've got. It sounds like the United States society is more compartmentalized than the UK society is, and that's.
Yeah, I would say comparing UK and the United States, it's like comparing apples and oranges for sure. Especially our healthcare system, very, very different.
Yeah. So you're getting a lot. It sounds like people that you're talking to, there's a lot of conflation of ideas, Lisa, is there? Because we're untrustworthy in one instance, therefore they'll be untrustworthy in all instances. Is that kind of
how do you decide what to believe, right?
Yeah.
And I asked the woman, well, how do you decide what information is true and what isn't? Because there's conflicting information on social media, on YouTube, on what the TV doctors are saying. And she said, well, I just look to see who has the most likes. And I thought, oh, no.
Yeah.
Because, CDC probably has hundreds of thousands of followers, but an influencer who knows nothing about health and science and believes a lot of incorrect information might have millions of followers. And so if that's our barometer, we've got a problem.
I mean, I found this, you always try and go as evidence-based as possible. But even then, you're not going to get it right every time. You try and apologize if you do get it wrong. But the evidence, when you're analysing the evidence, you can only go by the evidence that's available. And if evidence is selectively released by international or national organisations, it kind of leaves you reading between the lines a bit, and it gets really quite complicated. So all I can say is this is the evidence as best as I can understand it. I mean, having said that, I started as a psychiatric nurse when I was 18, and I'm 64 now, so I've literally done this all my life, nothing else. And for 30 years, I did a lot of academics where you're comparing different sorts of evidence. So that's kind of probably the best way to try and do it. But it's still difficult because all the evidence isn't there. It's
I know it is a problem, but we can never have all the evidence. So we talk to people about different kinds of research and different kinds of studies. The best study to understand how a drug's going to work in John versus Lisa is to have two versions of John and two versions of Lisa. But that's not possible.
Yeah.
So we do the best we can. And I know that when data are continually coming out, and then they might be conflicting, or it's a different study sample, and the interpretation by the researcher is different, it makes people skeptical. And the best example of this, I think, right now is this conversation about natural immunity, right?
Absolutely. Yeah.
We get pummeled on our YouTube channel for not talking about natural immunity. But the truth is, as an infectious disease doctor, I wholeheartedly believe in natural immunity, because that's the whole point of your body protecting you from something you've already had, like chickenpox. So before there was a vaccine for chickenpox, if you got chickenpox, I've had chickenpox as a kid. I've never had it again, right? So, but it's not one size fits all. That chickenpox narrative doesn't fit for every bacteria or every vaccine. And again, so remember our conversation just a few minutes ago about how rudimentary the understanding is about science. When you start talking about immunology and virology, it's very, very complex stuff. I don't even understand a lot of things about the immune system. So this narrative now that you have to get vaccinated in the face of data suggesting that natural immunity is also good. Like, that's not a surprise to me, because I always expected when people would ask me, I've had COVID, do I need to get vaccinated? I would say you could just get a booster. Why? Because you have some protection from natural immunity. The problem is we can't possibly study every single person who's had COVID to know how long the protection is going to last. And so, some people will say, well, that's just an excuse, but it's the truth. I don't know how long the protection lasts for every person from a vaccine either. So I think we're losing a lot of trust by not talking about this, because it's fair to say we don't have all the answers, but we don't do that. And so I think people think we're just pushing vaccines, whether there's a financial argument or, business argument, I don't know. But I think we at least owe it to people to say, there is protection from natural immunity. We just don't have all the answers. And then give people the information to decide about the booster.
And give them the uncertainties as well.
You have to, because that's the way you maintain the trust.
Yeah, we can't bluff here, can we?
What's that?
We can't bluff. If we don't know, we have to say we don't know.
I think there is some bluffing going on. And so when you see that, I think it just makes people skeptical and they turn off. And we don't want that.
Do you think part of the problem is we've got the government approach has got a sort of one size fits all? So everyone in a particular group should be vaccinated, rather than doing a sort of more bespoke approach. So you've got high levels of antibodies, therefore you've had the infection, therefore you don't need the vaccine at this stage. Are you doing any antibody testing?
No, very little. And I think it's
we're not either.
I think it's not really practical to do it on everybody, but I think if we could, and I'm sure there are some scientists out there figuring out how to find an antibody test that's sensitive enough and accessible, to make it more accessible. But for me to get my antibodies tested, I had to go to the doctor and then hope that the lab, wasn't going to send me a huge bill for it. I think it ultimately got paid for. But she said, I don't know if they're going to cover this. Like, why are we doing these antibody levels? And I pushed for it, and that's why I got it. But, I have some privileges most people don't. I will admit that. But most people don't have.
You probably do, because I asked very nicely several times and was told absolutely no. So basically, if you go to a GP in England, he won't do your antibodies.
Yeah, probably.
Well, first of all, you can't get to a GP in England. You talk to them on the phone. It's very difficult to get. You can get to them, of course, but it's difficult. But I asked about this, and they said, well, no, the blanket policy is we're not testing for antibodies in my practice. I mean, to me, this undermines the entire principle. I was always taught to assess, plan, implement, and evaluate the care on an individualized basis. And we're just doing the complete opposite of that. We're treating people as communities, not as individuals. And I think that's a big part of the problem. People don't trust because they know that what's true for Lisa is not necessarily true for John. And yet John and Lisa are being treated in exactly the same way. And I think that's part of the problem.
Yeah. Well, I think government messaging is very hard to nuance. Yeah. And I don't even know if they try. The issue with the antibody testing available for everyone is some of it is the interpretation, and then how often would you do it? So I did it for kicks because I could, and I'm sort of now thinking out loud, ashamed to admit that, but I think what information did it give me? It's a moment in time, and now here I am 6 months later. It could be zero. It could be 800. I don't know. And does it really give you useful information that you need? I think once upon a time, it would have been very useful. I don't know now with Omicron and such high levels of background infection rates. I think it's probably not that useful.
I think the most useful thing about it was if you test positive for COVID antibodies, then I think the antibodies themselves are fairly irrelevant because they'll wane pretty quickly. But if you've tested positive, it means you've been exposed to the antigen. Therefore, there will have been immunological stimulation of the B and T memory cells.
Right.
I mean, to me, that is the most important part. And I was talking to an Austrian doctor yesterday, and he said natural immunity has so far been indicated to last for 390 days. In many cases, and of course the 2003 SARS outbreak, people were still immune in 2020, 17 years later.
Yeah, so for years, yeah.
But of course this is a different virus. We don't know exactly what's going to happen, but it's there's
just so many questions, because I mean, if if that were true for this virus, I would be surprised. I was just thinking I'd be surprised that there are still a subset of people who are still getting very sick with Omicron. Sure, there are people who have chronic health conditions, they're immunocompromised.
Yeah.
But if they had some level of response from the boosters and vaccines, with their T cell and B cell response, why are they still getting so sick? But this just goes to show, like, these are still questions we don't know the answer to.
So there's people that are vaccinated are getting breakthrough hospitalizations, and
few and far between. Like, the data are so compelling around the efficacy of vaccines to keep people out of the hospital and from death. I mean, that's like unmistakable.
Yeah.
But the few that do break through, it's those folks who are frail, elderly folks, or folks with multiple chronic conditions. And so, and you could argue, well, maybe they wouldn't have had a good response to their vaccine anyway, and that's why they're there. But the only point I'm making is that the immune system is so complex. We can't respond to, every possible scenario.
I mean, I think my understanding is that the Omicron is slightly less pathogenic than Delta.
Yeah.
But if someone's exposed to Omicron who has no prior exposure, if they're completely naive to SARS coronavirus 2, they've had no vaccines and they've had no natural exposure, then they're still at significant risk.
Yeah, absolutely.
It's maybe not quite as high a risk as Delta, but not a lot less. So the reason we're seeing such a different response now to Omicron is largely because of the immunity. Less so because of the intrinsically reduced pathogenicity. I think that's probably.
Yeah, I think that's fair.
Probably where we're at. So, for someone to be exposed to Omicron who's had no vaccinations at all, unless they'd have natural immunity, then that's a significant risk, of course.
Yeah, and we still want those people to consider vaccination. But we still get some pushback from people, especially on our YouTube channel, about vaccinations, because they think if you're talking about vaccination and you're not talking about things like vitamin D and health and wellness interventions, that you're anti those things, and that's just not true. You can both things, right? But the truth is, in the United States, we are largely an unhealthy nation. So to tell someone to take vitamin D once they get COVID, I mean, the train has left the station. The vitamin D vitamin D data are very compelling.
Yeah.
For prevention.
Yeah. Yeah, that's right.
So if you take vitamin D before you get sick, then you're probably good. Like, it's helping. But if you are sick enough to go to the hospital, you're on a ventilator, like, you are deathly ill from COVID, I would never suggest that vitamin D should be a treatment.
No, it takes at least a week to for the vitamin D to be activated as it goes through liver, isn't it? But of course, you are obviously advocating for a healthy diet, lots of fruits, vegetables, exercise, weight loss, management of chronic conditions. Is that a problem, Lisa? Did you get people that have got type 2 diabetes and don't take their metformin, don't look after their diet? People with hypertension who don't take their hypotensives or don't have access to hypotensives? Is that an ongoing problem?
Oh, yes. And that's actually a big motivation for what we do, to help people understand why it's important, because all of these things are preventable. And it brings me to my latest soapbox issue. It's about my own metabolic health.
Yeah, so, please do.
I have been posting recently on my social channels about how I need to walk the walk. And, people are saying, oh, you're a trusted messenger. You're beautiful the way you are. Don't worry about people saying things about you. It's not that. And I can sum it up in a story, a fable I heard from my integrative medicine professor. And he said, a woman took her son to see Gandhi. I don't even know if this is true. That's why I call it a fable. I'm not sure if it's true.
apocryphal, we would say.
She took her son to see Gandhi, and she said, Gandhi, I cannot get my son to stop eating sweets. Can you please tell him? If you tell him, he'll listen to you. And Gandhi tells the mother to bring her child back in 2 weeks. So she comes back in 2 weeks, and she says, now can you tell him? He says, bring him back in another 2 weeks. So she comes back the third time, and he looks at the boy and he says, you must stop eating sweets. And the mother says, why couldn't you do that the first time I came? He said, because first I had to stop eating sweets.
Yeah. That's good. That's good.
That's
Yeah.
my fable, right? For my own, I used to be a very athletic, active person, snowboarding, cycling, playing tennis, hiking up mountains. And then somewhere along the way, I got really busy and stressed out and doing my work, and I stopped exercising, and the weight just started piling on.
Yeah.
And so where I'm going with this is recently, I was looking at the comments on one of my YouTube videos, because my weight gain is very noticeable on my videos. And someone said, well, this doctor looks metabolically unhealthy. And someone else said, I don't take advice from fat doctors. And it struck a chord because I've known for a long time I needed to reel this in. And so I've actually started losing weight and started focusing on my own metabolic health, because thankfully I'm not diabetic. I don't take medication for chronic diseases, but I was on the cusp. And I have to, walk the walk and follow my own advice. So, and if it was detracting from my message, then that's important too, because I don't want people to say, oh, well, this person's not credible. She's not credible because look at her. Like, why is she going to tell me to stop eating sweets? And clearly she's eating sweets. So you see, but we have a high background rate of chronic health conditions that I think put us in position for the disparities we're seeing with COVID-19.
Mm-hmm. And you have the whole repertoire, don't you? Especially in the Black community. You have the obesity, the hypertension, the diabetes, the dyslipidemia, the metabolic syndrome, and then all the complications that come from that, the retinopathy, the peripheral vascular disease, the diabetic nephropathy, and then of course all the vascular diseases that come as well.
But if you think about all the social conditions that people endure, especially in the Black community here, poor schools and education, food deserts. So we talked about that earlier, not having access to good food, healthy foods, or knowing how to prepare it. So many, a wealth of issues, violence in our neighborhoods, the trauma associated with living in certain zip codes, and not having access to the full range of preventive services easily available to you. Like, all of that is really contributing to these disparities and inequities we're seeing.
Yeah. Just say something, if you don't mind, Lisa, please, about mental health in your communities.
Yeah, well, and I think we're seeing just about every community is struggling with this, but particularly in the communities we serve, mental health and behavioral health issues have been a real struggle for us, because we don't have access to the range of services, and a lot of our mental health providers actually don't take insurance, and some only take cash.
So when people have a mental health problem, there's actually no treatment facility available in some cases.
We have some, but I think the challenge with mental health resources is that you need to match the service with the person. And so I think there have been a lot of behavioral health startups and companies and options that have cropped up over the last few years. But sometimes people don't know about them, and sometimes they're hard to access. So I like to do secret shopping. And when I was a provider in a health system, I was trying to get mental health services for some of my patients. And I actually called these places, because we would give out lists. These are the places you call to get a behavioral health visit. And they would say, I can't get through, or the appointment's 3 months from now. Like, people need help when they need it. So I tried to call and had the same experience and realized that our mental health services are not readily available to people, which is the promise of these, tech startups that are focused on behavioral health, but people still have challenges accessing them when they need it. And if someone's in crisis, like an opioid crisis, they're not going to use an app. They're not going to have the presence of mind to call someone to get help necessarily. And so I think we have to make sure the community is aware of these resources and we know how to navigate to get the help. And so I think all that's just broken, John.
So you've got anxiety and depression and the usual, a sprinkling of psychotic disorders, as you would expect. But you've got a lot of the opiate problem in the States has been well publicized. Is it still a big issue?
Oh yeah. And lately in the United States, there's a lot of discussion about it because it hit middle and upper income America. Mm-hmm. But we were struggling with opioid addiction in the, Black and underserved communities for a long time before that. And so it's not a new problem. It's just that it's being talked about more once it moved beyond, the poor and Black communities or poor disenfranchised communities. Yeah. Like many things, it's not a new phenomenon that happens.
It seems to me that there was a lot of illegal opiate use in the 60s, 70s, 80s, but then prescription opioids were sort of an overlapping problem on top of that kind of spread the problem out to what you might call more middle class communities. Is my impression correct about
yeah, that is correct. But it's also, what I'm saying about getting more attention, it's because it spilled from like poor Black or poor brown communities, whether it was, injection opioids or prescription opioids, it was a problem. But then once it spread to upper income communities, white communities, then it became much more visible and, much more pearl clutching around this issue. And I just think that just plays into the disparities that we continue to see and have seen at least my entire career and will continue to see probably.
Yeah. So as well as the educational resources that you're making for the communities that you're serving, Lisa, how are you trying to communicate with the wider academic community or the wider American community? I mean, are you trying to do some academic work, or are you trying to do some mainstream media publicity, or how are you trying to get this message out more broadly?
Yeah, we want to build a following in the communities we're serving. So we try to, and we have a long way to go in this regard. So I think using social media channels, partnering with, influencers, like you're an influencer, but most of your folks, are in the UK. They're not necessarily.
No, at least half of my views are in the States at the moment, Lisa.
Is that right?
Yeah.
Great. So then those folks who are in the States that are connected to some of these community organizations, we want them to tell their communities about Grapevine and follow us, tell us the kinds of content they want to see, the kinds of things they need help with. And then I probably will resume some mainstream media engagement. I haven't done very much of it during the pandemic at all, mostly because I've been out on the ground and that's, that takes up a lot of time and energy.
Yeah. So, are you hoping to collect some sort of empirical academic data to sort of give evidence for your contentions?
Yeah, I started Grapevine Health as a result of collecting data for a research project I was doing with Commonwealth Fund and realized where people are getting their trusted health information. A lot of it was on the Grapevine. And so that's where the name came from collecting those data. The other thing we learned, though, is what people are doing on their smartphones. So we were able to substantiate or to document that people who are poor also have access to technology. They have smartphones. The majority of them have smartphones. They may not have broadband, but they have smartphones and they can get on the internet. They send text messages. But I also documented what else they were doing on those phones. They're listening to music. They're watching YouTube videos. They're scrolling on social media. And guess what? By and large, health messengers are not really in those spaces. And so that's also part of our call to action. How do we create interesting, relatable content and put it in the places where people are already paying attention? So that's on our roadmap to grow the Grapevine brand.
I mean, in essence, you are an ethnographic researcher, aren't you? Because you actually live in the community that you serve. I mean, I won't give specific examples. I don't want to embarrass individuals, but I've seen people doing what they might call good work, and they might leave their sort of fairly comfortable house and they'll drive in their fairly comfortable car and they'll do the good work in this particular area. Then they'll drive home again at night, and you know that they're not really becoming of the people. They're not becoming flesh to those people. But you actually live in the area, and you share the inconvenience of grocery store deficiency, for example.
And it's hard. It's really hard to do that. You know, I developed sleep apnea. So, you know, along with my sort of metabolic challenges, part of that was just putting on weight because I wasn't walking in my neighborhood as much as I did when I lived somewhere else. And some of that is related to concerns about violence or having enough people out in the community with you to walk. So, you know, safety is sometimes a real issue.
So in your area, you're not free to walk around in the evening on your own, really?
Oh, I don't walk around in the evening, no. And actually have to drive more. So driving is definitely, I drive a lot more than when I lived uptown because I had a bicycle and I would take Metro. But now during the pandemic, you know, things have changed. I don't take Metro much at all anymore. So at least not right now. And I don't like wearing a mask. I'll be the first to say that. So being on Metro in those places, it's too much time in a mask for me. But I'm willing to wear the mask for the greater good when it's necessary. But if I can be out in open spaces without a lot of people around, I'll take it.
But it is particularly tragic that, you know, the level of community threat is such that you're not comfortable working out on your own in the evening. That's a real... There's a separate whole set of sociological issues there, but it's still pretty it's pretty sad that you can't do that, really.
Yeah, well, I'm moving back uptown because of these health issues, so it's okay.
But you've lived there for a few years. I mean, you've been immersed in that culture. You must understand it better than any other.
Yes, I do. 3.5 years.
Yeah.
And so I leave the community with a really deep understanding from being proximal. And understanding how stressful it is and how much distrust there is, and more importantly, why. Because as we're developing these solutions, we really have to understand why and where people are coming from, because they're justified in a lot of cases in their choices not to go see a healthcare provider.
And as someone who now understands that deeply, I can sense that you're feeling the responsibility of how you communicate that outside of other areas. So you keep communicating to the community and to the wider country. And of course, we'll put any links on that you would like to.
Yeah, no, I appreciate that. I appreciate your support.
We'll click the links.
Yeah, well, mostly to the Grapevine Health website, but we also have a Google number. We try to get out into the community if people want to send a question.
Oh, for sure.
That's another way we collect data, right? Because we can see the kinds of questions people have, but we haven't marketed enough for people to know that much about it. So.
But as well as that, I mean, obviously we support that, but it's also you're describing almost a new philosophical approach to healthcare, which is, I'm not sure I've quite assimilated it myself yet, but it's certainly an interesting, it's an approach that would work potentially in any community, potentially anywhere in the world, I would guess.
This approach is about convenience, relatability, and trusted messengers. So, information only gets you so far. I recognize that, but it opens the door and builds trust. So then someone can take the next step.
Yeah.
But if the next step is not convenient, relatable, respectful, then you're really getting nowhere. So we need to be able to build these bridges with the health system, and then have the health system be responsive to what people need.
Absolutely. And just to close, Lisa, pandemic wise, are we seeing more and more community immunity, herd immunity now? Are cases going to go down, or hospitalization is going to go down?
Well, they're already going down, and so I think so. I think we're close, and a lot of people aren't even talking about herd immunity anymore. But I think Omicron, once it was ushered in and was spreading like wildfire, I think there's been so much exposure to the coronavirus, or this coronavirus, that I'm really hopeful that once the rates go down, and we're still seeing the rates are still too high. So I hope we don't plateau at this level, and that the rates continue to come down. So.
And I know you saw the video of the friends of mine in Uganda who said that Omicron was the vaccine that we failed to develop. So basically they are seeing Omicron as a gift from God. That is how they're seeing Omicron. I mean, do you share that idea that Omicron has been probably? Go back to December when we had this chronic attrition of people getting sick all the time from Delta, and now Omicron is kind of. Do you see Omicron as the best possible thing that could have happened in that particular difficult circumstance?
I have to say it is a blessing in disguise in many ways. Yeah. Yeah, I would agree with that. Because again, back to this conversation about natural immunity. Yeah. For people who'd never been exposed to it, now they have some immunity. And what we're trying to do is reduce the transmission. And so even though you can still transmit, I still strongly believe that if you have some protection, the virus is not continually replicating. And the more virus you have, the more you can expose someone else. There is something to that science, even though a lot of people are poo-pooing it now and saying the transmission is just as much if you're vaccinated as if you're not. And I don't know if we know that that's 100% true.
But we are moving to endemicity. It's going to be endemic.
Yeah, I think we're there. Yeah.
So
I don't know if we need to continue having boosters after. I'm not getting another booster.
No, neither am I.
I'm on my T cells.
I think I get a booster every time I'm exposed to the endemic virus now.
Yeah.
As I am with thousands of other viruses that are already endemic.
Yeah.
That we live within this microbiological milieu in which we live and move and have our existence.
Yeah, the immune system is an amazing miracle, and it has many mysteries that we don't understand yet.
Yeah, for sure.
And the final thing I'll say, John, is that it's really unfortunate that we don't see the mRNA vaccines as the modern day miracle they are, and the scientific advancement they are. And it's because of all this politicization, all the confusing and conflicting information, that narrative has gotten lost. So, but hopefully one day people will look back and see how amazing it was.
I really hope that's true, but I am waiting for more longitudinal data as well.
Yeah, well, you're a scientist.
If only, Lisa. You're trying. You're a proper scientist and a proper medic, so that's great to hear your opinion. Anything else you want to tell us, Lisa, about?
No, I think that's a good conversation, John. I really appreciate you bringing me on again. It was great to catch up with you.
Something's going to come to you and really annoy you as soon as I click stop record. It's
It's okay. I've got my armor on now.
No, you're welcome back at any time, of course, Lisa. And great to talk to you. Great to see you looking so healthy, and I'm fascinated by what you're doing. I really think it is a potential new paradigm in health, and been fascinating to talk to you. And do come back when you think it's appropriate. It'd be great.
Okay,
Lisa,
great.
Thanks
a lot, John.
Thank you. Thank you.
Bye.